Hello everybody, this is lecture 5 of co-occurring disorders. In this lecture we're going to be covering trauma and stress-related disorders, which is briefly covered in the Atkins textbook on 195 to 207, and covered in more depth with the tip 57 readings that are also for today. Keep in mind that the page numbers for the reading 59 to 89, that will be the numbers on the actual pages of the PDF document. So don't look for the page count number on top of what it will say in the PDF. Look on the actual document, the actual paper that you're reading for those page numbers. And then also to talk about the dissociative identity disorders a bit as well in this lecture. Starting off, we will talk a little bit about just which trauma-related disorders we're going to be covering in detail here. It's going to be post-traumatic stress disorder, or PTSD. We'll also talk about acute stress disorder and adjustment disorder. We're not going to be talking quite as much about reactive attachment disorder or disinhibited social engagement disorder, because those disorders are not as often linked with substance use disorders as co-occurring issues. So first off, we're going to talk a bit about the diagnostic patterns revolving around PTSD and trauma. Average American, the lifetime prevalence rate of PTSD is about 7%, which is 5 million Americans in any given year. So those are two different rates. The lifetime is 7% of all Americans will be expected to give the diagnosis, to receive a diagnosis of PTSD over their lifetime, where in every given year it's estimated that 5 million people will in that year report having PTSD. Really important is to know the overlap rates between substance use disorders and PTSD between 20 and 50, so up to half of every individual who has a substance use disorder will also meet criteria for PTSD. So that's a lot, half almost. Roughly 30% or 1/3 of people with post-traumatic stress disorder will report having a substance use disorder. So we see a lot of correlation, coexistence between these two disorders, which is really important clinically to consider what that means, that the substance use and PTSD are so often lining up together. Roughly 90% of individuals with a substance use disorder have been exposed to some form of trauma or another. And I'm going to explain that in a bit more detail too, because it's really important to be able to distinguish between experiencing trauma and having all of the symptoms that would make up PTSD. PTSD is a very large disorder in terms of the diagnostic detail involved in it, so I'll get more into that a little bit later. One final thing to keep in mind on this slide is PTSD more commonly precedes a substance use disorder, which means somebody, for some reason or another, gets the disorder, PTSD, and then later on, after that, after they've experienced the trauma that's given them PTSD, they will then start to take on a substance use disorder, start abusing substances, perhaps in response to the trauma they've experienced. So let's get a few really important definitions out of the way here as well. The APA Dictionary of Psychology has this definition for trauma as a whole, which is any disturbing experience that results in significant fear, helplessness, dissociation, which we'll talk more about later, confusion, or other disruptive feelings intense enough to have a long-lasting negative effect on a person's attitudes, behaviors, or other aspects of functioning. So reading this definition, we see a fairly broad, inclusive manner of looking at what trauma means. It can be any type of experience. Of course, we know that we hone in on some particular things like natural disasters, warfare, poverty, abuse. Those are things that we typically think of trauma, but with this APA dictionary, we can really broaden this to anything that can cause lasting effects negatively on a person's attitudes, behaviors, and other aspects. What's really important too to keep in mind is that many people can experience trauma without necessarily developing PTSD. Many factors go into whether or not somebody, their likelihood of developing PTSD after experiencing trauma. Much research looks into genes, environment, gender, and history. An important point to keep from some research by Breer 2016 has shown that cumulative trauma predicts presented PTSD, or present PTSD. And basically what they're saying there is the more often you experience trauma, the more likely one of those incidents is going to lead to experiencing PTSD. Each subsequent experience of trauma can make somebody more vulnerable to developing PTSD. So the more experiences one has, the more vulnerable they will become over time. Another really important concept is that of complex trauma. This has been defined by National Child Traumatic Stress Network as exposure to prolonged, sequential, or simultaneous occurrences of maltreatment. This will include psychological maltreatment, neglect, physical and sexual abuse, and domestic violence. What's important here to keep in mind with complex trauma is that, yes, this is an intense form of trauma, but it's also prolonged, repeated, sequential, or simultaneous. So what we're seeing here is, a deeper history of repeated traumas is what we consider complex trauma. Exposure to these initial traumatic experiences and the resulting emotional dysregulation and the cost of safety, direction, and the ability to detect or respond to danger cues often sets off a chain of events leading to subsequent or repeated trauma exposure in adolescence and adulthood. So what they're describing here is a condition in of itself, that if you've experienced repeated, prolonged, intense forms of trauma, you are more likely to experience or more trauma in the future merely because of the way those traumas affect your ability to regulate your emotions internally and your ability to properly detect and respond to possible threats in your environment. Complex trauma corrodes a person in this way and makes them more vulnerable to trauma in the future. It makes them more vulnerable both psychologically and behaviorally. So very important to keep this in mind too when we think about trauma versus PTSD and how somebody can develop PTSD more likely if they've experienced complex trauma than individual isolated events. So let's jump into PTSD. It's a very big disorder with a lot of details to it. First and foremost, there has to be some form of exposure to actual or threatened death, serious injury, or sexual violence in at least one of these ways. Direct experience, witnessing in person as it occurs with somebody else, so like actually watching somebody else experience this form of trauma. Learning of events that occurred to a close family member or friend, must have been violent or some sort of random accident that was horrific. Experiencing repeated or extreme exposure to adverse details of other traumatic events. This can be first responders, police officers, or clinicians, therapists. And this is what we consider vicarious trauma, is when we immerse ourselves in understanding the details of somebody else's trauma. It may be less intense of an experience, but it can bring on a form of PTSD, or at least it qualifies as an exposure to something that can bring on symptoms of PTSD. Doesn't necessarily apply to electronic media or TV, though. What's also important to keep in mind here is that with this first criterion, exposure, what we see is exposure to trauma, but in a more severe way than the dictionary, the psychological dictionary, has defined it, right? What we see here is threatened death, serious injury, or sexual violence. So they're very specific with the types of trauma that often, or more often, or should bring on PTSD. So another important distinction to keep in there. Lots of traumas can affect somebody for a long time in their life, but may or may not actually become PTSD. So one thing I'll say is that there's quite a few criterion to PTSD. This is criterion B. Presence of one or more intrusive symptoms associated with a traumatic event, which can be any of these 5 symptoms. Recurrent, involuntary, and intrusive distressing memories of the event, so these recollections that come about without your permission or desire, they just hit you involuntarily. Distressing dreams with related affect and events, so related emotions that simulate the experience that the person's been through. These dreams don't have to be exact replications of the trauma. In fact, many times people will only report the feelings of it, this general vague fuzzy feeling of violence or unsafety. But those would be distressing dreams that are somehow related to the trauma. Dissociative reactions or flashbacks where somebody feels as if they're really back in that situation again while they're awake, very similar to the dream experience that they may have. Intense or prolonged psychological distress at exposure to internal or external cues associated with the events. And we can imagine that many things could cause both internal and external. Let's say somebody had been slapped by their father very often, and then somebody playfully slaps them on the arm. That could be both an external and internal trigger, right? Because the feeling of being slapped, that is an internal trigger, the sensation of it could bring about reminders of the prior abuse, where the person actually doing the slapping would be the external trigger, depending on how much that person is actually reminding the individual of the abuse. Also, marked physiological reactions to internal and external cues that resemble the traumatic event. So we see psychological distress and physiological reactions being two different things. And one would imagine the physiological reactions would be things like heart palpitations, sweating, probably things that look a lot like panic attacks or panic in general. All right, so the next criterion, persistent avoidance. So the one up here was intrusive symptoms associated with the traumatic event. The next here is persistent avoidance. So avoidance has to be one of the symptoms involved in PTSD. Avoidance is stimuli associated with traumatic events with at least one symptom of the symptoms being the following. Efforts to avoid distressing memories. Let me go ahead and fix the grammar here. With at least one of the following symptoms. One of the following. There we go. That looks a little bit better. Blow this back up here. Right, so the two symptoms related to persistent avoidance will either be efforts to avoid distressing memories, thoughts, or feelings associated with the traumatic event. So that would be a lot of internal work at trying to just forget about particular details. The other is avoidance of external reminders that arouse distressing memories, thoughts, or feelings about the trauma. So this one's fairly simple criterion, right? They're either trying to avoid thoughts and feelings, or they're trying to avoid external reminders of whatever it is that they had experienced in the past. The next slide here involves negative alterations in cognitions and mood that are associated with the traumatic event somehow, with at least two of these symptoms. Inability to remember important aspects of the event, so this could be a form of memory blockage as well. Persistent and exaggerated negative beliefs or expectations about self, others, and world. Distorted cognitions about the cause or consequences of the traumatic event. When we look at symptom 2 and 3, we see a theme here developing where someone who has been in PTSD may be experiencing a lot of blame or shame or beliefs that they were somehow to blame for the trauma itself. And this may carry on a lot to later on in life where they have very low self-worth. This is oftentimes connected to attachment theory, where if you're being abused by your caretaker, an instinctual motive we have is to blame ourselves in order to protect what we think about our caregiver. Because as children, we're dependent on our caregivers. We can't judge them harshly when we depend on them for survival, so we turn that inward as a way to protect the attachment bond. And so that's what a lot of this cognitions and mood symptom is getting to, is that symptoms oftentimes revolve around beliefs about self-worth, and your future, and the ability to have a successful life even. Self-efficacy plays a big part in this one too, because many people feel ineffective because they weren't able to stop the trauma and they felt very powerless, and that feeling can continue on in life and PTSD. The next symptoms are persistent negative emotional states such as fear, horror, anger, guilt, or shame, like we mentioned before, diminished interest or participation in significant activities, feelings of detachment or estrangement from others, and persistent inability to experience positive emotions. So a lot of these can even look a bit like depression, right? There is this kind of pattern of things that look like depression. However, these feelings and beliefs are more likely connected to the experiences they had of being mistreated at a younger age. One more group of symptoms here for PTSD is marked alterations in arousal and reactivity associated with the traumatic event, with at least two of the following symptoms: irritable behavior and angry outbursts, reckless or self-destructive behavior, hypervigilance, which is somebody who's, well, 3 and 4 kind of come together here. Hypervigilance and exaggerated startle response. So hypervigilance is someone who does a lot of checking, who may have an internal sense of unsafety and are doing a lot of checking. You also read a lot more about hypervigilance in the tip reading for this week. Exaggerated startle response is very easy to notice as somebody who you may bump into around the corner. They're going to jump much higher to someone else. So this is literally a much larger startle response than other people may have. They may experience problems with concentration, as well as sleep disturbance, which oftentimes may look like insomnia and may be insomnia as well, but is maybe more likely one of the symptoms of PTSD as well. Duration of these symptoms have to go on for at least a month or longer. What you see is there's a little bit of overlap between some of these symptoms as well. We see persistent negative emotional states as a symptom for the cognitions and mood, where we also see angry outbursts and irritable behavior and arousal activity. So I would like to see them at some point consolidate this definition of PTSD a bit, because we've got 5 different criterion areas with a variety of symptoms in each one of them. Altogether, it paints a very clear picture, but it can be a very overwhelming disorder to piece apart like this. Just to review quick, we have the exposure to actual or threatened death, serious injury, or sexual violence in one of these ways. We have intrusive symptoms, reminders of the thing that you went through. With those intrusive symptoms, we have avoidance, or efforts to avoid either internal or external reminders of the PTSD. Then we have cognitions and moods that is perpetually negative and base something around a lack of self-efficacy or self-worth. And then we have difficulties with arousal or activity, which is more often hypervigilance, tenseness, basically, and difficulties with sleep. Overall, together, we also want to look at some of the specifiers for PTSD. One is when someone may be experiencing a dissociative symptoms, either depersonalization or derealization. I'm going to cover that in more detail in the next section as well. One may also experience delayed expression to PTSD, where they're not actually experiencing these symptoms until sometime 6 months or longer after the actual trauma happened. This is an interesting thing about just how the brain wires and the stages that we go through when processing trauma. There is a freeze response that may happen for many people that they may not, that may delay their full expression of trauma. Additionally, we know that there is memory blockage issues as well, like with the cognitions and mood symptoms and ability to remember. So there's maybe some sort of memory blockage that doesn't get fully processed until some trigger comes along that reminds this person of what they experienced. And then it's also good to keep in mind that there are different criteria for individuals 6 years and younger when it comes to this disorder. Next up, we're going to talk about acute stress disorder, but I'm going to pause the slideshow for now and start up in section 2 for this next part.